Hi everyone, my name is Deanna Chaukos. I am a CL psychiatrist in Toronto at Sinai Health, where I am the physician lead for medical psychiatry, and I'm also an educator in the Temerty Medicine Faculty of Medicine at the University of Toronto. Thank you for having me today at ACLP 2025. I have no disclosures with respect to this presentation. And these are our learning objectives for today. I hope you'll leave today being able to describe adaptive expertise in health professions education and why it's essential for the care of patients with complexity. You'll be able to identify learning mechanisms that can support patient-centered integrated care for complex populations, and to identify characteristics of a knowledge-building community utilizing the HIV Psychiatry Echo as an example. This is our agenda. We'll talk about what adaptive expertise is, why it's important for the care of complex patients, how do we cultivate it at the individual level between the teacher-learner dyad and is team-based care, and also at a community of practice level toward knowledge-building communities. I hope you'll leave today knowing that the role of medical education is to produce future experts. We don't finish training as experts, but hopefully we end with the skills that will support future expertise. Adaptive expertise is a theoretical framework in health professions education that describes how experts operate. We know that experts do the following. They have flexibility in patient care. An expert applies an efficient solution to a known problem and can adapt knowledge to solve new problems. They are able to navigate ambiguity. They can innovate, adapt, or create new knowledge in the face of new problems. So they find themselves problem defining and problem solving simultaneously. Experts engage in continuous learning and integration. They can integrate the why of conceptual knowledge with the what of procedural knowledge. And this deep conceptual understanding allows them to move beyond efficient routine problem solving when it's required. Without this kind of integration, knowledge is static. Expertise should not be an accident of development. As I mentioned, adaptive expertise describes how experts operate, so we can move backwards in medical education to deliberately cultivate adaptive expert abilities in training. Expertise is a muscle that you flex. It's not a trait that you have or don't have. And as I mentioned, the purpose of education is to create future experts. What is medical complexity? You all know, because you're CL psychiatrists, medical complexity originates from interactions between patients and contextual factors, such as the health system and socioeconomic status. Complexity may indicate a limitation of the healthcare system, one that's reliant on standardization and better suited to address acute care visits or single disease problems. Patients with complexity present with multimorbidity, both psychiatric and medical illnesses, adverse childhood events and trauma history, and other social and structural barriers to health. This is where adaptive expertise comes in as part of the solution. Medical education has to confront the challenge of developing competent professionals prepared for future uncertainty, to teach our learners to move beyond evidence-based medicine, to ask questions like, does this pathway apply to the patient in front of me? Why and why not? And how do I act regardless? Traditional and reductionist approaches to education fail to account for this main feature of complex problems when there is no one right answer. And yet, physicians must act amidst uncertainty despite that. HIV psychiatry is a population of patients that represent significant complexity. We know that patients with HIV fall through the cracks due to structural exclusion. People living with HIV with psychiatric illness and substance use problems require care across hospital and community settings. And we know that amongst these different care providers, community and hospital-based, fragmentation is prevalent, and this is due to difficult to coordinate care. In the HIV sector in Ontario, where I work, the resources exist. However, fragmentation and barriers to patient-centered care means many still do not have access. Today, I will be sharing with you some of what we've learned from our qualitative education research. The purpose of our research has been to explore how adaptive expertise conceptual frameworks can help solve the educational and clinical challenges posed by complexity in the HIV sector and beyond. And the aim of our work has been to identify learning mechanisms that support expertise development and patient-centered integrated care. Our work is unique because we do this across different healthcare worker roles, clinical roles in hospital, and other community healthcare worker roles, case managers, peer workers, other community roles like public health nurses, pharmacists, etc. And of course, this work occurs across contexts. This is unique for interdisciplinary research, which often focuses in the hospital setting. And yet we know that to support patient-centered integrated care, we need to work across hospital and community contexts. From our education work, we have elucidated these additional learning mechanisms for adaptive expertise. First, I'll introduce them to you, and then we'll talk about how we can apply them in a broader community of practice. The first is fostering epistemic humility. This is awareness of the bounds of one's knowledge or what is knowable. Epistemic humility allows for inviting uncertainty, saying, I don't know. As a stance, inviting uncertainty facilitates continuous learning, like I talked about, and in clinical care, this leads to collaboration and perspective exchange. Engagement and perspective exchange, not simply task sharing, but actually active inquiry into the work of another, the lens of another, whether it be a healthcare worker, a peer worker, or a patient. And when we do this, it leads to improved innovation and improvisation and collaborative reformulation, which we'll talk about. Integrating knowledge across disciplines. When we engage in perspective exchange, it allows for integration of knowledge across roles, the patient role, clinical, community provider roles, and this promotes patient-centered care. When we invite uncertainty, it leads us to engage in perspective exchange, and this breaks down silos between roles. It supports true collaboration and more effectively addresses the multiple social and medical concerns of patients with complexity. And when this integration happens, we call it collaborative reformulation. Here you can see these learning mechanisms in a visual because, of course, they lead to one another and they often co-occur. There are evidence-based ways to cultivate epistemic humility. The first is invite uncertainty, do it explicitly, do it aloud, and do it without self-deprecation. I don't know is the beginning of a process. It's not the end of one. And it often leads to other self-efficacious learning mechanisms like perspective exchange. We can use uncertainty to create a time for telling. Schwartz describes a time for telling as creating an appetite for learning, helping a learner to notice their gap so that they're motivated towards the learning that the teacher can provide. The third is productive struggle. We know that when we allow learners to grapple with ambiguity, with not knowing, that this is when they are most primed for learning. And then finally, pragmatic empiricism. Make it explicit. Pragmatic empiricism is when a teacher and a learner speculate together about the next safe step, even amidst ambiguity. So it often looks like, if we do this treatment option, then it will help clarify this differential diagnosis. If alternatively this happens, then we might expect this. This kind of thinking allows learners to feel self-efficacious amidst ambiguity and to find the next safe step, how to act amidst ambiguity. As I mentioned, I don't know marks the beginning of the process, not the end of one. Uncertainty in medicine has been criticized as a way for physicians to relinquish their responsibility amidst ambiguity or uncertainty. And when we start with "I don't know" and allow for that to be the beginning of a process, that's not what's happening. In fact, it's allowing for perspective exchange to be the next step. We know that perspective exchange is learned, it's modeled. When medical trainees see their staff psychiatrist calling caseworkers and community workers, getting collateral, not just clinical information, but relevant, diverse other kinds of information, this is important. It tells them this is what a physician does. When community workers, CMDs, engage them as part of the circle of care, they were more likely to attend patient appointments themselves, follow up on medication adherence, and advocate for their clients to consider psychiatric help. We know that perspective exchange requires psychological safety. Epistemic humility helps create psychological safety for risk-taking. When there's a traditional power hierarchy, like there is between teacher and learner, between MD and community worker, it's important that that person with the traditional power invites uncertainty, models "I don't know," and inquires about perspective exchange. What do you think about this case? For community workers, perspective exchange was perceived as a big risk and one that had significant positive consequences when it occurred in a psychologically safe work environment. It meant that community workers had increased future willingness to share their expertise with other healthcare workers. And that's when integration happens. Collaborative reformulation is when there's a new understanding of the problem that integrates these diverse lens and expertise. For community workers, when collaborative reformulation happens, it improves awareness of team-based care, how to engage hospital infrastructure, and it even challenged anti-psychiatry viewpoints in the community. For psychiatrists, it led to improved awareness and taking responsibility for their role in anti-oppression work, and it also improved recruitment of distributed or informal teams across hospital and community. And for patients, patients describe their care as less stigmatizing, more accessible, holistic, and coordinated. So these are the learning mechanisms that our work has elucidated, and now I'm going to show you how we applied them to a community of practice like the HIV Psychiatry ECHO. ECHO is an evidence-based distance education model that utilizes a hub and spoke setup. HIV Psychiatry ECHO specifically targeted community workers as an audience. Most ECHOs have a clinical audience. Our ECHO focused on non-clinical community caseworkers and peer workers. And the purpose of this was to develop an integrated approach and an approach to mental health competencies amongst community workers. The ECHO emphasizes brief didactic learning with case-based discussion, and we've been very lucky to have support from the Ontario HIV Treatment Network to continue our ECHO 2 cycles annually every year, and this has been incredibly successful in our HIV sector at a time when virtual participation in educational offerings, I think, may be at an all-time low post-pandemic. Our ECHO HIV Psychiatry includes robust participation and engagement that I think really speaks to the power of these learning mechanisms. Over time, as we've studied our ECHO, we have noticed that when we engage the learning mechanisms that support adaptive expertise, epistemic humility, inviting uncertainty, facilitating perspective exchange toward collaborative reformulation, our community of practice has shifted from a community of practice to a knowledge-building community. And you can see here the differences between a COP and a KBC. Where a COP emphasizes shared interest in generating answers, a KBC emphasizes collective inquiry and generating questions, and thinking about how do we adapt or improve existing knowledge toward new solutions. With respect to process, a COP focuses on sharing of best practices, and a KBC focuses instead on building improvable ideas This is where that collaborative reformulation comes in. Perspective exchange occurs, and with those new perspectives, we're integrating new aspects and able to improve ideas towards solving what can be ambiguous problems. And then you can see there that a KBC really does focus on idea diversity, thinking about different kinds of knowledge as equally valuable, and that perspective exchange where we truly learn the work of another is essential for this. And here I've demonstrated how adaptive expert learning mechanisms are supported in a knowledge building community. And I won't go into this in particular, except to say that we have seen this community come together where community caseworkers, peer workers, clinicians are able to learn the work of another and feel self-efficacious towards solving problems that I think make all of us experience maybe a sense of futility in the work that we do. Problems that feel difficult to solve amidst a healthcare system that's not designed to solve it. And when we bring each other together towards these kinds of psychologically safe learning environments for risk taking, we really do see beautiful collaboration occur that has patient impacts. There are challenges to this work. I'll mention that education is often overlooked part of QI or models of care work, and I think it is an important lens that needs to be integrated in this kind of work. We, of course, need systematic healthcare solutions. Education won't be the only solution for complexity. And the ECHO and other programs like it do take time, and time is a scarce resource always for busy healthcare workers. Finally, another challenge is how do we demonstrate patient-level impact? A lot of our research relies on provider-level accounts of how their practice has changed. These are the conclusions I'll leave you with. The purpose of education is to develop future experts. We shouldn't leave this up to chance. There are evidence-supported learning mechanisms that support expert abilities, epistemic humility, inviting uncertainty, which leads to perspective exchange, and integration of those diverse perspectives allows for integration and collaborative reformulation. We've shown that this can be cultivated in individual teaching dyads or team-based environments, as well as in large communities of practice towards knowledge-building communities. And KBCs are interesting because they do have potential for solving complex problems in healthcare. Thank you. I want to thank our broader team who are all represented here. And I'll share my references and then pause.